Well, thank you, Chris. It's really a pleasure to be here. I think it's been a terrific day. I was asked to talk about what this meeting would look like 10 years from now. I'm not sure that I'm any more prepared to do that than any of you, except that I'm probably older than any of you, so I have a little bit of perspective about how much things can change. At the same time, how much some things don't change. What I'd like to do today is to just review what we've heard. And then to ask what we haven't heard and what we should be thinking about that maybe isn't foremost in our minds. As a starting point, I'll end with what I think is the bottom line. I think we all need to recognize that the field that we're entering into here is still very, very young. And there's so much we don't know, and there's so many mistakes that we're making that we can't see. You could have the same conversation about stem cells or blockchain or any of these other things that have captured the imagination of people as being potentially game-changing, but it's too early. And most of what we've talked about today are sort of at the conceptual level, but not yet at the data-driven level where we can look at real evidence to know what works and what doesn't. So I like to think about 3 phases of what we have to do. There's a phase of feasibility, there's a phase of showing validity, and there's a phase of clinical utility. And I think we're coming out of that feasibility period. We're working on the validity. We're still quite far from utility. So let's go quickly through what we've heard today. Matt started us off with the 10 questions. I didn't list all 10 of them here. They're on the outside of the room here, and they've been passed out as well. I think just to give you a sense of what, to me, was the take-home from that, was that came out of a very mindful process of hearing from lots of different voices, and it captured at least a few things that we still are going to struggle with. How do you balance online and offline, the safety efficacy questions, the whole issue of, we talked a little bit, or not yet, maybe about the digital divide and what does access really mean here, and the question about whether digital has something really to offer us. I want to come back to this issue of what research methods will matter. Chris followed up with this, I love this image because I think it's what we're stuck with. And it is really this kind of disconnect between the world of feasibility and building validity and then the world of actually having something that's useful in clinical practice. We're not there yet. We're kind of right at the first part of this, and still we're going to have to figure out how to get everything onto a single track. I tend to think about this from a standpoint of asking, what are the problems we're trying to solve? That's so important to do when you talk about tech, because it is so easy to get enamored of the gimmickry and the possibilities and how cool it all is. But let's try to remember what's gotten in the way in the past and how do we want to use this to make a difference. I'll give you 4 things that I think have kept us from really changing the rates of morbidity and mortality in mental illness. One, to me, is the problems we have with diagnosis. A second is that most of the people who we'd want to help are not coming to see us. They're not engaged. Even with IAPT in this country, we're still leaving more than half of the people off the plate. Lots of reasons for that. But that is, I think, one critical reason why population data doesn't change, even though every one of us has the sense that what we do is effective. It doesn't matter at the population because most people don't come to see us. When they do come, often what they find is a quality of care that really doesn't match what they might get in the rest of medicine. It's highly fragmented, it's certainly reactive and episodic. And the final point, and the one that we've just heard about a little bit from both Payam and from Matthew, is the problem of measurement. And as Peter Drucker said in a completely different context, as a business guru, we don't manage what we don't measure. And I think that is a fundamental problem in this field that continues to plague us. And of course, what we'll come back to is whether the digital revolution can help to solve that. So just to come back to what we heard this morning, and I'll kind of begin to graph this onto this set of 4 problems and 4 potential solutions. Kathy took us through what I think is a really fantastic example of how a targeted approach to a set of problems around childhood anxiety, where you've got something that you know is effective, and you know that many people are seeking care, and yet so few people are getting what works. And so can you close that gap? And I think she showed convincingly that there are ways to do that if you include parents and children in the design. So super interesting to see how that will work out. We'll need more data to know what the ultimate impact is and whether it can get onto that single track of moving from validity to actual usability and utility. Duncan and Manjul took us through that spectacular story around the champions of Shenga. That might have been where the soundtrack was from, I don't know. But at the same time, talked about could they move this now into something that could begin to look at childhood anxiety, and what would that look like, and how to build those sorts of games. And of course, it was a great example of what you can do in the private sector. Building a video game is like building great music. You don't want to do this badly. So if you're going to do it, you have to do it very well. And it does take the kinds of resources that are pretty hard to put together in an academic environment that can be done either in a public-private partnership or through a private sector effort. Edward took us through this story about the eco-web, and here you had now an RCT that's been completed or is in process to try to understand something about how we can now, for a more population approach, change this, what he called, and I think the term is a good one, kind of emotional wellness, or getting to a point where you can focus on that whole suite of problems around cognitive training, emotional regulation, and emotional knowledge to give kids the resources that can build resilience. And it's a great example of how we can begin to do this at scale. In the second session, we heard about real-world impact, and we had 3 examples there as well. Richard took us through the video CBT example. I thought it was really interesting the way he talked about that, recognizing that in some ways the tech wasn't really that transformative, but the impact was, and that there was a lot one can do even with a kind of web-based CBT approach. We heard from Michael about Alpha Stim, now moving to a kind of tech that was a little more cutting edge, around direct current stimulation, and interestingly really focused on the cost implications of that, and whether if you add this into what we can do for CBT, in this case, in the context of IAPT, whether we can get better results at a lower cost. And then Daniel took us through what the kinds of work that Oxford VR is doing. My heart is still racing a little bit from walking out on that plank and looking around. I'm still kind of fascinated by the floating whale, which I thought was a brilliant idea. But what I think he's taking us into with his team is a whole new way to identify targets of influence. So by looking at something like social engagement and overcoming social avoidance in psychosis, the opportunity to have an impact that just frankly would probably be impossible in the offline world. Even if we decided that's what we wanted to go after, it'd be very difficult to do in the way that you can do it online, or do it with VR. So incredibly interesting for where that may take us in studying social withdrawal. And then finally, we heard Richard, who talked to us about digital well-being and how one could begin. He used the Own It app to what he called harness the fire. And I want to actually build on that in my remarks, because I think what he said to us, and it can't be said strongly enough, is that we have to think carefully about what the tools could do. And so rather than simply taking the CBT manual and putting it online, we should be asking us, how can we harness the fire to be able to take the kinds of treatments that we know work and make them far, far better, awesomely better, because of the sorts of things you could do, VR being an outstanding example, but with AR, with better measurement, with many other things that you could add to it. So, given that, what are we not talking about? Or what do we need to be thinking about, especially as we prepare for 2028? Although I imagine Chris is still just worried about 2019 and the next MindTech meeting. But I think we will be around in 2028. I think there's a lot to work on here. So first, back to this harnessing the fire concept that Richard introduced, that we can do better if we simply think about capturing the things that the digital world can now provide. It is crazy that we are giving basically 1998 psychotherapy online instead of asking, what could it look like if it's interactive, if it's personalized, if it's iterative, and completely shifting as people begin to improve or begin to relapse. You saw a piece of that with Daniel's presentation about VR, but there's no reason that couldn't be done on a smartphone in an interactive way on a whole range of different interventions. We didn't talk much today about trust. It's a huge issue, and I guess a question that I'd love to engage MindTech on is who's going to do this? I do honestly believe we're going to transform mental health care, even perhaps more than any other part of healthcare. But I don't yet know who will do that. I think it's likely that Google and Facebook, Microsoft, and most of all Alibaba have the resources to do this. But I'm not sure that any of us want them to be the ones to do it. I don't know the public would trust them to do it based on the techlash and everything we've seen in the last year about how data get used and how privacy is or is not protected. There are small tech companies like our own that have begun to do this, and you've heard from some today. They may have more trust, maybe not, but they may not have the resources to bring it all together. So they can build a widget, they can build an app, they can build a process. But as I'll say in a moment, we're going to need much more than that. And then you've got the public sector, the academic sector, or even government-funded players who I think are more trusted, but simply don't have the resources. They don't have the designers, they don't have the engineers. They can't bring the pieces to bear. I worked at Google. At Google, when we wanted to take on a hard problem, this is a very hard problem, we would start with $100 million and 100 engineers. And our argument was anything less than that meant the problem wasn't worth our time. That's hard to do in an academic environment. I put this line up before I got to hear from Pam and from Matthew, but clearly measurement is, I'll say this over and over again, critical to being able to make progress here. And it isn't just measurement, it's linking measurement to what you do. It's creating a closed loop system. We're getting better about doing this in diabetes and hypertension. We've got to do this in this mental health space. We are like diabetes before you could measure blood glucose, right? And now we are beginning to measure, and I think what Matthew and Pam showed you was just a brilliant set of examples of what those measurements are going to look like. We need to have a lot more information about how they get collected and how they get understood. But it's what you do with them that's going to really matter. And figuring out a way to close the loop, and then, because you're measuring, know whether your intervention is successful or not. That's what we mean by a learning healthcare system. That's where we need to be. And I have no doubt we'll be there by 2028. But we have to get there through this pathway of showing that the measurements are valid, the interventions are effective, and that they are, in fact, going to be used in clinical care. Surprisingly, we've been very UK focused. There's been very little talk about the global environment, although there is no topic today around mental health that we talked about that isn't every bit as much of a problem in Botswana, Uganda, Vietnam, China, India, as it is here. In fact, it's more of a problem, often with less access. So the kinds of tools we're talking about, especially those that involve a smartphone, when you have 3 billion smartphones in play, are wonderfully appropriate for transforming global mental health. Some of you, in talks I've given recently, I talked a little bit about a recent trip to Tanzania, where I was out in a very remote area of Maasai land, about 70 kilometers, 60 kilometers from the nearest paved road. And every Maasai warrior I met had 3 things. He had a spear, He had his sheep and goats, and he had a smartphone. That's a different world, and if we're building tools for smartphones, we're building tools that can transform global mental health. That's fantastic. We ought to be thinking about how one does that. And finally, we used to say at Google that we were preparing for the post-app world. And in a world where you have 2 million apps, you've pretty much saturated the world that you want. Nobody's going to be able to navigate that in a good way. And most of us may have 30 to 40 to 50 apps on our phones. 96% is based on 4 of them, of 96% of use. So what this is going to look like as we go forward, we don't know. But it's very clear that the way that we're used to doing RCTs and the way we're used to doing regulation does not fit a world that's changing every 6 months. And believe me, the world that we've been talking about today, which is largely based on smartphones and keyboard use or some other aspect of the phone, could be very different in 3 to 4 years. Remember, the iPhone, which has led a lot of that smartphone revolution, was the first version of that was 2007. So we're still at the very beginning of what could be a very interesting process of new technologies. And so what those technologies will look like, we just don't know. Let me just really quickly take you through one aspect of the measurement that Mindstrong particularly is interested in, but it's only one way of thinking about this. Smartphone signals, we've got the sensors that you heard about from Matthew. In this case, sociality could include just text out versus text in, calls out versus calls in, although a few people under the age of 30 would ever use a smartphone to talk on. Voice and speech, you can ask people to actually use the smartphone to talk on, and you can capture an enormous amount of information from both the coherence and the sentiment and the actual pace and volume, other aspects of the voice. We look at human-computer interaction, HCI, which is basically how you use a keyboard, not so much what you're typing, but how you're typing. It's an old cybersecurity tool that was used as a forensic tool there to track hackers by the patterns of digital interaction with the phone. Machine learning comes into play here by looking at specific patterns and creating these digital phenotypes. There are a couple of interesting posters upstairs. If you missed them, I'll just mention quickly that there's a whole other channel to the phone that you can think about as well. We call it digital exhaust, and it's looking at social media posts or Google search or any kind of search history to try to understand whether it's suicidal ideation or the beginning of a psychotic process. A lot more invasive. Actually, frankly, it's pretty creepy to look at that, but there are ways to do it, at least within a research context, that might make this very useful. As many of you know, these AI personal assistants, we talked before about Amazon's Echo or Apple Siri or Google Home. They are collecting an enormous number, the Siri team, I think about 500 a day, people who are confessing to suicidal impulses, more than any of us would hear in an office setting. So it's a different world, and we need to think about how that world could play out. So just an example of the human-computer interaction data. This is looking at a single subject as a 42-year-old woman with bipolar disorder and borderline personality. The area in blue is when she was hospitalized after about 6 weeks of growing psychotic symptoms. She had very little insight into that. She actually denied that she was psychotic. But you can see the difference between pre-hospitalization and then when she's medicated and she's post-hospital. The critical point here is that those two measures, cognitive control, and memory, were not actually measured actively. We didn't ask her to fill out a form for this. These were simply pulling smartphone signals off passively from the normal use of her phone, which means that for the first time, it may be possible, as Matthew was saying, to get these daily readouts of how people are thinking, how they're feeling, and to do that over long periods of time, not just days, but weeks, months, and years. To understand for the first time something that's been very hard for us to capture, which is what is the longitudinal trajectory of these illnesses, and to begin then to potentially change the way that we treat people as well as the way we think about diagnosis. So we have this new opportunity, which I think will completely completely change the way we do behavioral science, that we can collect mood, cognition, and behavior objectively, continuously. We can do it in their home environment or their work environment. And of course, the fact that it's entirely passive means that for the first time, we've got enormous amounts of data that can go on for long periods of time. We're at a point, actually, where the data collection isn't the challenge is making sense of it. And so if you ask what's going to change over the next couple of years, it may be less around the sensors and the type of data and much more about the analytics that we need to develop, which with AI we're making great progress, but that's still very, very tough. Matthew mentioned in passing that there's lots of missing data, and figuring out how to handle that and how to get some insights of putting all these data streams together is super complicated. So to just come sort of full circle and try to come to a close pretty quickly here, what I've been talking about is this digital phenotyping piece. The brilliant thing here is that this same form factor, the phone, can also be the basis for doing interventions and for helping clinicians to manage care in a different way. But the critical piece of this is that when you put any of those interventions, the peer support or the coaching or the crisis intervention, whatever it happens to be, in play, or when you improve the care coordination, you can look at the impact because you're measuring. You've got real-time outputs of that. So you can create this kind of learning healthcare system, which is exactly what we're going to need if we really do want to bend the curve. So my argument here is that we can take each of those four problems. The diagnostic problem will be able, I think, to begin to solve because we're going to have deeper insight into at least cognition and mood and behavior. The engagement happens through this peer support world where people will engage anonymously on platforms that let them not only get help, but amazingly give help, which we've discovered is probably the most empowering thing that we can do with technology. The lack of quality begins to get resolved by having transparency and knowing exactly what it is that people are receiving when they're receiving care, because all of this is digital. And finally, I've just been telling you about what we can do in terms of measurement. We like to think about, this is just going back to Matthew's point about that early detection, we like to think about this as a kind of digital smoke alarm. And it's true that not everybody wants a smoke alarm, but if your home has burned down, you really want a smoke alarm. So for people who have been struggling and need help with disease management, they have a chronic illness, they've been hospitalized, or they've made a suicide attempt, they know this matters. And being able to predict recovery, predict relapse, really does make a difference. Now, most of the people in this room realize that this is a really exciting time and that it seems straightforward, and it absolutely isn't. I think Matthew made the comment that there's a lot of hype here. There is hype. There's also, this is incredibly difficult to do. And I think we're at a point where, I think it was Chris who showed that the hype curve this morning. We're sort of at that point where we're having the realization about how difficult it is without hopefully falling into this trough of disillusionment. We've got to figure out just the right amount of balance here. I think there are two pieces that we have to fix most of all. One is we do have to prove the value of this. We have to do it rigorously. We have to do it really carefully. And we have to do it quickly because the tech changes so quickly. The value, I mean, not in terms of economics, but does it work? That is, does it change outcomes? Will people use it? And although academic investigators don't think about this that much, but does it build efficiency? When I was at Google, we pitched this fantastic data collection scheme to one of the largest healthcare provider companies in the United States, and the chief medical officer said, I don't want more data, I want more time. So you give me something that will save 5 seconds in every clinical interaction, and I'm interested. You give me something that will require 5 seconds more in every clinical interaction, and it is a non-starter. I don't even want to hear about it. So efficiency really matters, and making it simple, and that's how we're going to have to move from validity once we have that established to utility. We're going to have to show that in the world of clinical care, either online or offline, this not only works, and it's not only engaging, but it builds efficiency. And if we do that, we're only halfway there. The other half is we've got to build this with trust. And that means, to me, providing transparency, full agency to the users, and doing this with responsibility so that we are, in fact, protecting privacy. The easiest way for us, I think, as developers and as people in this room who care about this field, sort of, to me, the North Star is to say, are we empowering patients and families with data? Are we giving them the ability to manage better? Are we giving them agency and helping them to get better outcomes and to function better? So for 2028, what I would say is that we want to think about moving from the world we're in now, where we have maybe 1,000 different efforts to develop apps, to putting all that together. Right? We don't need another 100 apps. We need a way to put all this together as an operating system. We need to create a whole new healthcare system that's both online and offline. Honestly, I don't know who is going to do that, but it is going to happen. It will happen before 2028, and it will change everything. So right now, we're very focused on social anxiety versus depression versus psychosis, and we'll have 100 different tools. How that all comes together is going to be the critical question of the next decade. I like to think about the world we were in a decade ago, before Google Maps, where if you were moving to London and you rented a car, good luck, right? Because finding your way around would be incredibly difficult. The Uber culture didn't exist yet. And now you have thousands, much to the dismay of the taxi cab industry, you have thousands of people who know nothing about the geography of London who are able to function like taxi cabs, right? Because they have a tool that tells them how to navigate in a way that would have been unthinkable a decade ago. In fact, those tools today allow us to navigate any place in the world. Google Maps has literally mapped every structure and every road on the entire planet. That's crazy. What would that look like for mental health? What if we had the tools that would allow any clinician anywhere to be able to function as a master clinician? Whether that's someone in an emergency room in primary care or someone in a village in a remote part of Tanzania, because they have access to a smartphone and they have individual data that allows them to monitor. And they have tools, for instance, to be able to convert speech and voice signals to a measure of thought disorder or a measure of depression. That is not impossible. We have a lot of what we need to do that, but we have to build that in a way that doesn't today exist. And then we have to think about how all of this begins to both democratize care and to empower users. I don't think we're there yet, but that is what will ultimately, I think, bend the curve. I'm just going to give you, before I finish, one kind of conceptual example, because otherwise this begins to seem so remote in a way. If you think about the problem of suicide and you map out where we have failed to bend the curve, and this is a bigger problem in the US than the UK, the US suicide rate numbers out this week show a 30% increase. 30% increase since 1999. That's amazing. We need to come up with a set of predictive signals. We need to be able to intervene just in time, and we need to be able to manage and monitor following an event. We have tools for every piece of this, and we need to now begin to show their validity and bring them together in a way that can prove the utility proposition. I think this is going to happen, and I think it could happen easily in the next decade. And I honestly believe this will, in fact, bring the rate down any place where we can put this entire ecosystem, this kind of operating system, into place. It's not going to happen right away. It will take both the high-tech and a high-touch approach. And I'll end with this quote, which says, we always overestimate the change that will occur in the next 2 years, but we underestimate the change that will occur in the next 10. This is early days. I like to say we're in Act 1 of a 5-act play. I can't wait to see what Acts 2, 3, 4, and 5 will look like. But I think we're all in for a really interesting show. Thank you very much.